Thanks, Rini, for inviting me for this course. I'll be basically taking you through a few very, very simple and straightforward common issues that one can face during glaucoma diagnosis. There's nothing very spectacular about my presentation, but these are things that one would like to keep on reminding everyone so that these mistakes are not made again and again. The first thing that I would like to talk to you about is the CD ratio. We all are used to mentioning cup disc ratio for a very long period of time. We still do so. And this is the very classic picture which has come in both the European Glaucoma Society guidelines and the Asia Pacific guidelines, just to emphasize the point that in the population you can have these three type of optic disc sizes. You can have the small disc, the medium sized disc and the large sized disc. And in all these three, which is shown in this picture, the amount of neural tissue is exactly the same. So because this is a small disc, this neural tissue seems to be filling the disc, a moderate here, and a very large disc there. Because of the disc size is large, the cup appears to be larger. In fact, the amount of neural tissue is pretty much same. So we always tend to look at this disc with suspicion and tend to over-diagnose glaucoma or investigate glaucoma. But more dangerously, we tend to overlook the small discs which are more prone for glaucoma. Even a very small notch in a disc like this can be really significant. So that is the importance of the neural rim. So we are not worried about the cup, we are not worried about the cup disc ratio, we are worried about how much of neural rim tissue is lost in glaucoma. So this is what is called the DDLS classification or the DDLS grading of the disc size, where you can find that you have this small, average size and large size disc, and you have grades for each one of these disc sizes, localized notches, large cupping and things like that. It's practically quite a difficult scale to use, and because of that it has not become very, very popular. But at the end of the day, I would just like to emphasize 3 points. Number one is just a value of cup disc ratio does not convey the actual optic nerve head damage. You can have a small disc of 0.4 with a localized notch, which is very typical of glaucoma, and a lot of damage can occur. And you can have a 0.8 cup disc ratio with a uniform normal neuroretinal rim, which can be absolutely normal. So this is just the point that I want to emphasize here. The second point that I would like to emphasize is to look around the optic disc. Never miss a RNFL defect, because our tendency is to always look at the disc and not look away from the disc. And just to emphasize this, the prevalence of true RNFL defects in the normal population is less than 3%. So if you can pick up an RNFL defect, most often you are looking at a case of glaucoma. We all know that they are fine silvery striations seen around the optic disc, more concentrated in the upper and lower poles due to anatomical reasons that we all know. And you have to look around the optic disc for these things. Number 3, a very typical field defect that you see, you can immediately say that this is a glaucomatous field, but this is actually due to a tilted disc syndrome. So this is not a glaucomatous field defect, although the field defect is very typical. This is due to a tilted disc, and you have to look very, very carefully at the optic disc before you really jump into a diagnosis of glaucoma. Just to take you through a few pictures where small excavations or colobomatous changes in the optic disc can really mimic large RNFL defects that you have here, and they produce very typical glaucomatous field defects. The clincher here is that the upper part of the disc may be reasonably normal without any cupping, and if you see those really cut off excavations, always think of non-glaucomatous causes. This was the field of this particular patient, and this is another patient with an inferior coloboma. Another point that you have to, which helps you make a diagnosis, are these extra colobomas or outside the disc colobomas that you see, and these are situations which is most likely to be non-glaucomatous, and this is the field defect of this particular patient. But just to emphasize this point, the optic disc is a great mimicker, and so you have to be very, very careful in. But mind you, such patients can also develop glaucoma. So that is the take-home point. If you have a if you're sure that it is a coloboma, fine. But that patient can also develop glaucoma at some point of time. It's not that they will never develop glaucoma, and so that is the one that you have to look of. Disc hemorrhages are something that we know that it's an important indicator of some sort of ischemic activity at the surface of the optic disc. It shows that the glaucoma in that particular patient is not very well controlled. Most of them occur in normal tension glaucoma, much more than the open angle and the glaucoma suspects. 95% are located within a few clock hours of focal RNFL defects. They tend to come and go. So always look, when you look at the optic disc for glaucoma, look for optic disc hemorrhages. And when you see an optic disc hemorrhage, unless proven otherwise, you are looking at a case of glaucoma. You can have an occasional optic disc hemorrhage with a PVD or some rare bleeding diathesis, but most often, if you see an optic disc hemorrhage, you are dealing with a case of glaucoma. The advanced field defect, something like this, if you see, always look at the values here, and especially if you see a very, very normal macular field, these are a large error or a large learning defect, and when this particular patient, this field was repeated, this was pretty much normal. So never jump into a diagnosis of glaucoma by looking at the optic disc by the field alone, and do a careful examination of the optic disc, and if they don't match, always repeat a field. So the moment you see an optic disc, the field should come to your mind. So if you have seen a normal disc, your mental picture should be that this field will be normal. Or if you see a localized notch in the inferior part, immediately a superior arcuate defect or a superior arcuate scotoma should come to your mind. So that is the way you have to imagine what the field or what to expect in a field that should be taken into consideration. Occasionally you can get these abnormally sensitive fields where you get these large areas with very high sensitivity which is abnormal outside the macular area. These are called white scotomas, and this is just to emphasize the point that once in a while, at least in these situations, you have to look at the raw numbers in the field chart, and if you see values of 45 or 50 outside the macular area, we know that the maximum you can get in a young patient in a macular area is about 38 or 40. So obviously you can't get a value of 50 outside the macular area. If you see so, it's most probably a high false positive error that is occurring. Look at the already poor fields very, very carefully. If you have a field like this, there's no point in repeating this 30-2 field again and again, because you're not going to get any new information from this field. This is just an advanced field defect. In such situations, you have to look at the smaller fields, the central area of the fields, the macular fields, which will give you more and more information as to whether this particular patient is progressing or not. So use programs like 10-2 or macula, and this will also help you look at macular splits in case you are going to go in for a trabeculectomy. The isolated poor field is something that you have to be very wary about. This was a patient who had 3 fields done elsewhere. The third field, which was done outside, had some defects, and then he came to me for an opinion, but actually the field was normal when it was repeated. Once in a while you can get these isolated bad fields. But the point there is that you have to also keep in mind that conditions like venous occlusion, anterior ischemic optic neuropathy, neurological causes, these are all comorbidities can occur in these glaucomatous fields. So before you say this is just a bad field or an occasional bad field, also have a look at the retina to rule out these conditions. Has the field improved? I asked my fellow, and she very dutifully said, yes, this field has improved. Probably this field was not done properly, but if you look at the program, it is actually due to a change in program. One is a 30-2, the other one is a 10-2. It's actually not improved. You are just looking at a different field. So change in perimetry programs, please be very careful. I'm not saying these are all common things that we make, but please keep these things in mind and try to repeat the same program during follow-up. Neurologic fields are something that you have to be very, very careful. These are very typical hemianopias that you see in patients. This was, I remember this elderly gentleman who underwent bilateral cataract surgery, very clean cataract surgery, but he kept on complaining. He had 6/6 vision in both eyes, kept on complaining, I cannot read, I'm very uncomfortable. Then he gives me a history of stroke, and then a field was done, and he had a hemianopia like this. So these patients, you unhappy cataract patients, once in a while you need to do a field to rule out neurological causes, and also ask for history of stroke. Preperimetric glaucoma is a definite reality. It's not an imaginary thing. This was a disc which was dismissed as almost normal, and then there was a small notch here. When we went back and looked at the field, you could see a very small optic disc RNFL defect here. I'll just take a minute. So that is pre-perimetric glaucoma, and you can have also what is called a green disease due to certain variations in thickness while the OCT is being captured. In an actual glaucoma with an optic disc change with an actual field defect, you can also get a fully green RNFL OCT. So whenever you see a green OCT, do not dismiss it as normal. So just to summarize, glaucoma, as we all know, is a jigsaw puzzle. Various things have to fit into place for you to make a diagnosis. Do not make the diagnosis by using a single diagnostic tool. Many factors, risk factors have to be looked into before you finally make the diagnosis to start treatment. And in spite of all the new technologies that we have in our hand today, a careful examination of the optic nerve head with the slit lamp biometry with your 78D or a 90D lens still remains the gold standard in diagnosis and follow-up in open-angle glaucoma. Thank you very much.